Good morning, colleagues. We begin the second lecture. I hope that all you were present and have listened to the first lecture, but I'm not sure. And that's why I invite you to the second lecture. In the first lecture, we have spoken about the common problems of stomatological oncology. We have spoken about the about the theoretical and practical aspects of the oncology, especially from the oral cavity. And now the second lecture will be about the clinical manifestation of the cancer. It is very important for you. You know what? I'm sure that I am sure now that 1 moment, excuse me. Yes, let us proceed. We are speaking now about the clinical manifestation. I want only to repeat what localization of the cancer, they belong to the oral cavity cancer that are lip, the down and upper, anterior 2/3 of tongue, buccal mucosa, floor of the mouth, retromolar trigon, upper gingiva, and hard palate. That is your region as a stomatologist. But do not forget that you are physicians, doctors, and have to pay attention to every pathological processes that you observe in your patient. And now concrete about the clinical manifestation. First of all oral squam cells cancer that are the type of histological cancer for absolutely majority of tumors of the oral cavity, of the mucous, lip, tongue, buccals, and so on. The oral squam cell cancer, or OSCC. Now, clinical manifestation. The history. The clinical appearance of oral cancer is highly variable and includes ulcer, red or white areas, lumps, or fissures. Some oral squam cell cancers arise in apparently normal mucosa, but many are presented by clinically obvious pre-malignant lesions, especially erythroplasia, red patch, leukoplakia, white patch, epictetic leukoplakia, red and white, or varicose leukoplakia, and many others are associated with such lesions, especially in Southeast Asia. Erythroplastic lesions are the red plaques that in the last 85% of cases show frank malignancy and severe dysplasia. In contrast, most white lesions are not malignant or premalignant. I will repeat that the red lesions are more dangerous than the white one, because the red lesions, they in 85% are malignant, and the white, they are not very often malignant. Erythroplakia, it is the red one, affects patients of either sex in their 6th and 7th decade and typically involve the floor of the mouth, the ventrum of the tongue, or the soft palate. Carcinomas are seen 17 times more frequently in erythroplakia than in leukoplakia, but leukoplakias are far more common. That's why red oral lesions are usually more dangerous than the white lesion. The prevalence of malignant transformation in leukoplakia ranges from 3 to 33% over 10 years. Homologous leukoplakias are only very occasionally premalignant, but expected on varicose leukoplakias are more likely to be premalignant. Malignant cases can be as high as 36% when moderate or severe dysplasia in leukoplakia is present. Be aware that single ulcer, lumps, red patches, or white patches, particularly if they persist more than 3 weeks, may be manifestations of the malignancy. Oral squamous cell carcinoma may present it as following: a red lesion, a granulation ulcer with fissuring or raising exophyte margins, a white mixed white and red lesion, a lump, sometimes with abnormal supplying blood vessels and indurating lumps, also a firm infiltration, a non-healthy extraction, shocked, a lesion fixed to deeper tissues or to overlying skin of mucosa. This is potentially malignant lesions of oral squamous cell carcinomas. What are the physician sites? A systemic and thorough examination of the mouth, faces, and cervical lymph nodes should be carried out by clinicians trained by the diagnosis of oral diseases, and a general physician examination is indicated. Dental practitioners are trained in the examination of the mouth. Advanced caries, periodontal disease, or apical lesion may need early attention, especially if radiotherapy is to be used in management of the tumor. Examine the teeth, parodontum, and entire mucosa in good lighting. Lesions always must be pulped after inspection to detect induration and fixation to deeper tissues. Oral mucous white patches usually result from the increased keratizing of candidos. Currently, the term leukoplakia usually is restricted to white patches for which a cause cannot be established. Therefore, the term implies a diagnosis by excision. It means lichen planus candidosis. The term leukoplakia also is used inspectively of the presence or absence of epithelium dysplasia. Leukoplakia is a clinical term for persistent adherent white patch with no histological connotation and no implied premalignant potential. Keratosis is the term now commonly used. Oral carcinoma also can appear as a white patch. Most lip cancers present on the lower lip at the mucosocutaneous junction as a chronic small lump, ulcer, or scraped lesion. Most intraoral cancer present in the middle third of the lateral margin of the tongue with an erythroplastic component are sometimes in duration. Late tongue cancer may manifest it as an exophyte lesion, an ulcer, or an area of superficial ulceration with induration. A typical malignant ulcer is hard with hyper up and often bedded or rolled edges and granular floor. The floor of the mouth is the second most common intraoral site of cancer and more commonly is associated with leukoplakia. Most cancer arise in the anterior floor of the mouth as an indurated mass that soon ulcerates, resulting in slurring of speech. Carcinoma of the alveolar of gingiva mostly are seen in the mandibular, premolar, or molar region, usually as a lump, a polyp, or ulcer. The underlying alveolar bone is invaded in 50% of cases, even in the absence of radiograph changes, and advanced teeth may be not firmly found. Carcinoma of the buccal mucosa mostly are seen at the commissure of the retromolar area. Most are ulcerated lumps. Some arise in candidal leukoplakias. Lymph node examination is the paramount importance in general examination, and possibly endoscopy may be indicated to detect metastasis or second primary tumor. 30 to 80% of patients with oral cancer have metastases in the cervical lymph nodes at presentation. Overall cancer predominantly metastases locally and to regional lymph nodes, primary in the anterior neck, later disseminations in the lungs, liver, or bones may occur. In practical terms, ipsilateral, enlarged, firm or hard, regional lymph nodes in the patient with obvious oral carcinoma are likely to include the metastasis. The chronic oral lesion should be regarded with suspicion, especially when found in an older patient. The lesion appear or with induration, fixation to underlying tissues. Any recent changes in appearance associated lymphadenopathy or no obvious explanation for the lesion. Now, about some moments they are important by diagnosis. Finding the history and clinical examination by trained diagnostics are the primary indication for the oral squam cell carcinoma. But the diagnosis must be confirmed histologically. And now I shall put your attention about the possibility of incisional biopsy, guided whether appropriate by vital staining in accessio and confirmation to the diagnosis. A biopsy must be performed on any oral mucosa. Lesions suggestive of cancer, including any ulcer not healing within 2-3 weeks. When an ulcer doesn't heal 2-3 weeks, you have to make the incisional biopsy. In vivo staining may help when it is difficult to decide which area of biopsy is the most appropriate, particularly if widespread lesions are present. Staining with toluidine blue followed by a rice with 1% acid, and then saline may be stained and airs most suggestive of findings and indicate those that need to have a biopsy. Oral carcinoma in situ and early invasive carcinoma have to affinity for toluidine blue, and although several false positive results may be accounted. Then I want to underline this incisional biopsy is the most important method of diagnosis that we have by the suspicion of cancer of the oral cavity. Then we have lymph node biopsy. A biopsy is performed based on the regional lymph nodes suggestive of cancer, using a fine bore needle to aspirate cells for cytological examination. That means we have two kinds of morphological. It is histology and cytology. High histology, it is Incisional biopsy and cytology is the biopsy performing with a fine bore needle to aspiration biopsy. Then we have also the imaging studies. Chest, X-ray, and endoscopy are available in exclusion synchronous second primary tumors. You have to take enough that very often the tumor is not only the single tumor in the oral cavity, but it can be have a synchronous tumor, for instance, in esophagus, in stomach, in bowel, lung, and so on. And that's why in the next clinical trainings, and we have with you 5 clinical trainings, we shall speak also about the tumors, first of all, of the digestive tract. That means that the chest radiography may be indicated since the lungs are the most common site of metastasis and the site of second primary carcinomas. Radiography, sometimes including axillary computer-aided tomography or possibly other imaging techniques, may be needed to determine the spread of some tumors, particularly to exclude bone invasion and lymph node involvement. Other imaging investigation, including MRI or computer tomography of the primary site of the heart, of the head or neck, and of suspected sites of distant metastasis. MRI of the neck can be used to delineate the extent of cervical node metastasis. Other investigation that occasionally can be useful include radionuclide scans. Bone scans are of little value in screening because they are positive only when bone involvement is symptomatic. Bone scans primarily are used to determine the extent of tumor spread. Liver radionuclide scans show abnormal findings in as many as 6% of patients with cancer of the head and neck, but 2/3 are false positive findings. Therefore, liver scans normally are not indicated. Laboratory studies. The principles are to confirm the positive or negative diagnosis and to determine whether the malignant disease is present elsewhere, including the following: blood tests, including the full blood picture and hemoglobin and liver function tests, may reveal metastasis in advanced disease. What about the different diagnosis, differential diagnosis? The main aim of differential diagnosis is to define the character of node elements. Enlarged nodes in a patient with an oral carcinoma may be caused by infection, reactive hyperplasia secondary to the tumor, or metastatic diseases. Occasionally, a lymph node is detected in the absence of any obvious primary tumor. If we have such a position, the metastatic tumor in the lymph nodes without the primary localization. that such a situation we see not rare in our patient. It is problem for practical physician. You as a not oncologist, don't, for you is the suspicion and the primary diagnosis, not the finally that we will for the specialist. But the treatment it will be only for the specialist. And that's why I shall speak only short about the treatment. Surgery and radiation alone or in combination are the cornerstones of curative treatment in oral cavity cancer. The surgical care, controversial resection of surgery, laser surgery, cryotherapy, electrocautery are surgical treatment modalities. Surgery aims are to remove the primary tumor together with a margin of clinically normal tissue to ensure complete excision of malignant tissue. Surgery thus provides a one-stage definitive procedure from which the patient normally recovers for the most part within 10-14 days. Although modern reconstructive techniques can produce good orofacial aesthetics and function, neither can be assured totally. Cancer centers receive many patients with advanced disease, and many operations fail to remove the tumor completely, resulting in a poor outcome and recurrence of the tumor. Ensure that the patient is as prepared as possible for the measure surgery, particularly in terms of general anesthesia, partial blood loss, and ability to metabolize drug. In addition, manage any potential dense or oral problems preoperatively are avoided. Surgery provides the following possibilities: complete tumor or lymph node excision with full histological examination for staging with implication for prognosis and the need of adjuvant therapy. Then, primary disadvantages are preoperatively mortality and morbidity, but modern techniques have to decrease them and the aesthetic and functional defects significantly. Ablation surgery excises the cancer ideally with the least of 2 cm margin of clinically normal tissue. If at least one mouse is clinical signs of invasion, it is reasonable to presume others may be involved and the most be removed by traditional radical neck dissection. Functional neck dissection modified and preserved the jugular sternomastoid accessory nerve, while ensuring complete removal of mouth cancer. Reconstruction and tailoring to the patient's ability to cope with a long operation and the risk of the significant morbidity. I want to tell you some words about the radiotherapy. Can be performed by external beams radiation. Radiation and surgery are frequently enjoyed together. As a very general guideline, in the absence of clinically identification lymphatic split, small lesions, T1 and 2, are equally well served by either radiation or surgery. For the tumors 3, 4, the clinically evident nodal metastasis and 1 to 3 combined treatment with radiation and surgery is indicated. Very important is the chemotherapy. Cytotoxic drugs which have selective action on cells of the mitotic cycle kill regenerating epithelial cells. Therefore, the simultaneous use of chemotherapy and radiotherapy results to move severe and prolonged mucous toxicity. The chemotherapy doesn't have the capacity to cure oral squamous cell cancer. It can bring about a considerable reduction of tumor cell population, volume and density. And we have two kinds of chemotherapy. Neoadjuvant therapy is used in the treatment of curable cancer, which precede irradiation and surgery. That means that we begin with the chemotherapy that is used before the radical surgery or radiation. It is called neoadjuvant. The adjuvant chemotherapy, it is those chemotherapy that it is used after the radical therapy to minimize the possibility of local recurrence or metastasis. The prognosis of oral squamous cell carcinoma is site-dependent. For intraoral carcinoma, the 5-year survival rate may be as low as 30% for posterior lesions presenting late, as they often do. For lip carcinoma, the 5-year survival rate often is more than 70%. It is all that I wanted to tell you in the second lecture. We shall speak more concrete in our clinical lecture, clinical treatment. I hope that in the nearest future, our online lectures and clinical training will be changed in the offline. That means that I can see your faces, and you can see our patient. And with a great satisfaction, I will show you the patient in our clinic. That's all, and I will tell you farewell, and I wait you in the next hour clinical training. We have 2 lectures, and both 2 lectures I have read. The next week, you can see it on Wednesday online. Goodbye.